Okay, everyone. I thought what I would do today is go back to basics, and given that it's the end of the year and some of you will be taking your exams in a few months, I thought I would just again review some of the basic principles involved in making an acid-base diagnosis. So not many of you know, but there actually evolved three separate approaches for how to approach clinical acid-base diagnosis. And in the 1960s, Schwartz and Rallman came up with what is now called the bicarbonate centric approach. But there was another competing way to approach acid-base diagnosis that was developed by Astrup and Sigurd Andersen in the 1960s. And you may or may not have heard of base excess. Have any of you heard of that in some of your earlier years of training? You can unmute. I'm just wondering if anyone's heard of base excess.
Yes, yeah. And I think in the
So,
ICU, they,
yeah, so unfortunately, it still continues in many hospitals. But basically, the thought was that if you take blood and acidify it back to pH 7.4, you can calculate how much acid or base was needed, and that was called base excess. And the problem with it is that it's not a whole body in vivo approach. It's done in vitro, and there are buffers in vivo that are not accounted for. So it really fell out of favor, even though a lot of surgeons and ICU folks still use it in North America and different countries. But basically, it's a problem because it doesn't take into consideration whole body buffers, whereas the bicarbonate centric approach does. And then some of you may have heard of the Stewart strong ion approach. Has anyone heard of that? People who train in other countries have heard of it. And again, the ICU folks and the intensivists and a lot of pulmonary people in different countries have now incorporated Stewart's strong ion approach. Has anyone heard of that? You can unmute. Okay, well, basically there are several conceptual problems with it. It has to do with chicken and egg or causal relationships. Stewart and his followers say that protons and bicarbonate are not causally related to the acid-base changes. It really throws a wrench into how people have been thinking about this for years. And what they have come up with is a parameter called the strong ion approach. It can simplistically be thought of as ions that don't change their charge, like sodium and chloride. So for instance, they will say that it's the sodium chloride difference that causes the acid base changes. And several years ago, in the mid 2000s, in 2008, I think it was, I wrote a review article with Jeff Crowd and Mintry on a critique of the Stewart approach in Kidney International. You might want to read that. And there have been a number of review articles since then critiquing these different approaches. You may want to become familiar with it because it depends where you practice, but there are people that are adamant on using the Stewart approach, and it just differs so much conceptually from the bicarbonate centric approach that it's really worth becoming familiar with so you can make cogent arguments when you see patients. Okay, so what I thought of, what I wanted to do today was just start off again familiarizing you with the bicarbonate buffer system. And it is an important buffer system in blood. It is the buffer system that is assessed in the bicarbonate centric approach. So you need to be familiar with its components. And so it's no different than really when you bubble any aqueous solution with carbon dioxide in this instance, to create seltzer. But our blood and this bottle of seltzer have the same components of the bicarbonate buffer system. And there are four. There isn't just bicarbonate shown here. There's also carbon dioxide, as you might expect, but there's things that people don't think about. And one of them is carbonic acid and carbonate. So when you bubble a solution with carbon dioxide, you end up with four substances being created, and they're at equilibrium with each other. And by equilibrium, it means they interconvert and at equilibrium, the concentrations don't change. So this is what we call the bicarbonate buffer system. It has four components, and the other concept is that the concentrations are very different. We know that bicarbonate is around 24 millimolar, assuming the pH is 7.4 here. The carbon dioxide concentration is actually 1.2 millimolar, and that's important. We'll talk about that a little bit later. But we can ignore, and we typically don't think about clinically, the carbonic acid concentration just because it's so low. It's 4 micromolar compared to the millimolar range. We're dealing with something that's 1,000 times less in concentration, and the carbonate at pH 7.4 is 30 micromolar. It gets more and more prevalent as you raise the pH because there are actually two pKs. There's the pK where carbonic acid is converted into bicarbonate, and there's another pK where bicarbonate is actually converted into carbonate at higher pHs. So at the pHs that we're dealing with clinically, we're really not dealing with this reaction. We're really dealing with the middle reaction here, the deprotonation or the protonation of carbonic acid. So we typically can ignore the carbonic acid and the carbonate, even though in human blood and in your patients, these are floating around in solution. And also they're never measured clinically, so they're just ignored. But remember, ignoring them doesn't mean they're not there. Now, we have another substance that we have measured in our comprehensive metabolic panel, and that's called the total CO2. Now, medical students and residents, and hopefully not you folks as renal fellows, should not be calling this bicarbonate. So if you're still doing that clinically after this lecture, please stop doing it. It's called the total CO2, which means the total, and CO2 is not a good word because obviously CO2 is one of the components, one of the four components here. It should be called the total carbonated species that belong to the bicarbonate buffer system, but that's just too many words. So it's been called the total CO2. Some people call it CO2. I don't like that either because CO2 can be confused with the PCO2, the gaseous form of carbon dioxide. You'll also see it called TCO2, which is just a short form for total CO2. So the best thing to really call it is the total CO2 or TCO2, and it is not equal to bicarbonate. It's equal to all four of them summed. Now, most of it is bicarbonate. So if this comes back at 25, the bicarbonate that comes back from your blood gases is most of it, which is why people erroneously call it bicarbonate. But it also sums up the other components, most of which is dissolved carbon dioxide, which is about 1 millimolar. And as mentioned, the carbonate and carbonic acid are very low, so you can ignore them. So the bottom line is what you get from your comprehensive metabolic panel is called the total CO2. So please call it that from now on. And it represents mostly bicarbonate, but it also includes some dissolved carbon dioxide, which is usually with a PCO2 of 40, 1.2 millimolar. But it does change. So you could have your total CO2 change, not only because the bicarbonate changes, but because the dissolved CO2 changes because you have respiratory acid-based disorders. So you can have someone with a bicarbonate of 24 and the total CO2 comes back at 26 or 27 simply because someone's got a severe respiratory acidosis and the bicarbonate has not changed at all, and people just continuously ignore that fact. So just to simplify things again, we can ignore the carbonate and the carbonic acid concentration. The total CO2 from the metabolic panel is bicarbonate plus the dissolved CO2, and the dissolved CO2 is calculated by taking your PCO2, so let's say it's 40 times 0.03, which is called the solubility coefficient of carbon dioxide. Every gas has a solubility coefficient. Nitrogen does, oxygen does. The solubility coefficient for carbon dioxide at 37 degrees at the pressures we deal with, and the ionic strengths of the other substances in blood is around 0.03. And that's how we get the 1.2. But again, you can see if this is 80, this is going to be 2.4. So it really depends on the the PCO2. So when we measure blood gases, we don't get the total CO2. The total CO2 comes back from our metabolic panel. What we get from the blood gases are two things that we measure, and then one of them is calculated. So the blood gas machine measures the hydrogen ion concentration, actually the negative log of that, and it measures the PCO2, and it calculates the bicarbonate. So clinically and in biology and in chemistry, we don't have a way of measuring bicarbonate. It's calculated from the measurement of the PCO2 with a PCO2 electrode and a pH electrode. Now, the equation it uses for calculating it can either be the Henderson-Hasselbalch equation, which I'm not showing here. It has log terms in it. This is a short form of the Henderson-Hasselbalch equation called the Henderson equation, which combines the various constants into one constant here, and then takes anti-log. So you end up with a number that's 24. And if you put 24 into this equation and then convert the pH to hydrogen ion concentration, which you have to be able to do because pH isn't in this equation. It's the actual hydrogen ion concentration in nanomoles per liter. If you plug in the PCO2 of 40 and 40, because the normal pH at 7.4, the hydrogen ion concentration is 40 nanomoles per liter, you'll end up with a bicarbonate of 24. Okay, so remember that when you do a blood gas, whether it's venous or arterial, the bicarbonate you get back is calculated. If the pH electrode is not working or the PCO2 electrode is not working, you're going to end up with an erroneous number here. It's not measured like the total CO2 is from your metabolic panel. But that doesn't mean, some people think because it's calculated, it's not a correct value. That's also erroneous. Just because it's calculated doesn't mean it's not the true number. As long as your pH and PCO2 were measured correctly, the bicarbonate you get back from the blood gases is a true number. So the other reason for knowing the Henderson equation, not only because that's what can be used to calculate the bicarbonate simply without having to use the Henderson-Hasselbalch equation, is because these parameters that are in the equation represent organ physiology. The lungs are what determines the PCO2, and the kidneys determine the bicarbonate. Just want to say that because you can't plug in pH into the formula, you should be able in your mind to have a rough idea of what the hydrogen ion concentration is, just so you can plug it into the Henderson equation to check that the numbers are right. But also that you get a feel of what the hydrogen ion concentration is at the various pHs. Now, remember, the units here are nanomoles per liter as opposed to millimoles per liter. So we're dealing with numbers here that are 1/millionth the concentration of bicarbonate. So just to remember very quickly, you can do it at bedside. If the pH is 7, that's a hydrogen ion concentration of 100. If the pH is 7, you just keep taking 80% of the previous number. That's how you do it quickly. 7.1 is 80, 7.2 is 64. Just 80% of the previous number to get the next one. And you'll be able to interpolate in between also if you have numbers in between, pH values in between. So it's a quick and dirty way at the bedside of knowing what the hydrogen ion concentration is compared to the pH. Now, it just happens that what evolved clinically was to use pH. It isn't just because these numbers are very small that clinicians use hydrogen ion concentration or don't use hydrogen ion concentration, but use the pH. But it's also because the voltage on the pH electrode varies linearly with pH and not hydrogen ion concentration. So there's a thermodynamic reason. And in fact, that's true of all ion-sensitive electrodes. It's the same with the sodium electrode or potassium electrode. The voltage that the electrode gives you varies linearly with the log of the activity of the substance you're measuring. So we could actually have evolved to use the negative log of the sodium concentration and get that value when we're assessing sodium clinically. But the only one that evolved clinically to use the negative log of the concentration is hydrogen ion concentration. But clearly cells in your body don't see pH. They see the activity of the hydrogen ion concentration. This is just a creation of humans to assess the values clinically. Now, the other important concept is the values that we typically think of are only male values. So again, we have our Henderson equation, and the question is, what are the normal values in this equation? And the 40 for the hydrogen ion concentration, 40 for the PCO2, and the 24 are male numbers. Now, women have the same hydrogen ion concentration of 40, but it's achieved by having a different PCO2 and bicarbonate. So you don't see a PCO2 of 40 in women. It's typically 37, 38, and the bicarbonate is not 24, it's 23 or less. And you might think these are, not important differences. They're so close to what the male numbers are. But if you want to make exact acid-base diagnoses, you need to know what the normal values are, because remember, we're always comparing to what the either population means are or that person in particular. And remember also, as we'll show, women who, when they're pregnant, get a chronic respiratory alkalosis. The PCO2 is around 32 or 33 in each trimester. So it's important to know what it is normally. And also, as I had mentioned before, when women ovulate, when progesterone goes up, it stimulates the medulla and the PCO2 acutely falls. So there's a dynamic change throughout the cycle in ventilation, and therefore what the PCO2 is. There are also arterial venous differences which you have to be aware of, and not shown here, there are arterial venous differences in men and women. So this shows male numbers. These are male venous numbers. In females, the numbers would be different on the venous side also, not just that this would be 38 and 23. And these are normal differences, and they're fine if you want to make an acid-base diagnosis, as long as you know what the normal values are. They're not good for assessing, obviously, oxygenation of the human body, but for acid-base diagnoses, they're fine. You just have to start with different normal values. Now, notice here the PCO2 difference between the artery and the vein. It's normally 3 higher than the artery, and that's because the cells are adding carbon dioxide to the blood, and they add it on the venous side, the venous blood flowing by them. And then when the blood gets to the lung, the PCO2 decreases because the lungs get rid of carbon dioxide and you get back to 40. Now, people years ago used to look at this venous arterial difference. They don't anymore. You guys could do that, and you probably should do it if you're interested, because it varies with the cardiac output. And if you think about it, the slower the flow of blood going past the cells, the more carbon dioxide per unit volume is going to be added. And so as the cardiac output drops, the venous arterial PCO2 difference increases. And there's actually this formula that you can use that most people aren't aware of. It's called the PCO2 gap. It's the venous arterial PCO2 difference equals some constant over the cardiac output. Now, typically, this is around 15. And so if you have a cardiac output of 5, the gap is normally 3 millimeters of mercury. So 3 times 5 equals 15. This doesn't change typically. And so let's say your cardiac output went from 5 to 2.5. Well, this would double. And so there's a hyperbolic relationship. It's like the same sort of thought as GFR versus the creatinine concentration. When they're multiplied together, give you a constant, the creatinine excretion rate. So it's similar thinking here, and that's a hyperbolic relationship too. The relationship between GFR and creatinine is hyperbolic. It's the same thing here. So if you have a patient whose cardiac output is 2 or 1, you're going to find a much bigger arterial venous PCO2 gap. And so it's just a very nice, quick way, if you're not sure if someone's getting into trouble as far as their cardiac output, of getting gases on both and looking at the difference. If it's 3, their cardiac output's probably normal. If it starts becoming 6 or 7 or 8 or 9, you're dealing with assuming nothing else is going on, with a drop in the cardiac output. So just keep that in mind. It's something residents and renal fellows and 99% of attendings aren't aware, but it's just a quick and dirty way of assessing someone's cardiac output if you're nervous at night with a patient or in the ER and you don't have access to to knowing what the cardiac output is actually. Now, the parameters in this formula, like everything else in nephrology, have to do with input-output differences. So nephrology can be just summarized basically as a subspecialty that deals with input-output discrepancies, depending on what substance you're talking about and the reasons for that. And it's the same with these numbers. So the concept is that the PCO2 is kept constant at 40, but that's not because you don't have a dynamic situation. You have a production, so an input side, and you have an excretion side. The carbon dioxide is coming into the system and it's gotten rid of, and normally those are equal, and so the PCO2 stays at 40. Now, normally we make about 20 moles of carbon dioxide a day. That's our mitochondria in the Krebs cycle, and the lungs get rid of it. So you have equality of input-output, and nothing changes. That's like for potassium, sodium, water, everything else that we measure in blood. If you have a constant concentration, it means the input and output are equal. Now, just to give you an idea, to make seltzer, you only have to add 0.16 moles of carbon dioxide. So much, much smaller than we're dealing with clinically every day in a human body. We're generating, getting rid of 20 moles a day. Now, what about bicarbonate? Well, bicarbonate is kept constant also, but it's a different issue. First of all, it's freely filtered, and we have a blood concentration of 24 millimolar and a GFR of about 140 liters a day, roughly. That means that roughly 3.5 moles of bicarbonate are coming through all our glomeruli every day. Remember, we have about 1 million glomeruli in each kidney, so this is coming through all 2 million of them. And that's roughly equal to a box of Arm & Hammer baking soda. But remember, none of that gets out in the urine. It's all absorbed by the nephron, about 70–80% of the proximal tubule, about 10–15% in the thick ascending limb, and then about 2 or 3% in the collecting duct. The proximal tubule does most of the reclamation. If that didn't occur in about 4 hours, you would have all the bicarbonate in the toilet and you'd be dead long before that. So it's essential that in all mammals, we have something after the filtration system. We have a nephron that reclaims that bicarbonate, so that in human urine, basically have absolutely no bicarbonate. It's in the micromolar range if you measured it. So it's essential that the nephron reclaims this filter load of bicarbonate. And when it doesn't, we have something called renal tubular acidosis, and we call it proximal renal tubular acidosis because usually it's the proximal tubule that has transport abnormalities that lead to defective bicarbonate reabsorption. It is clinically possible that it would be the thick ascending limb that would lead to RTA also. It just, nothing has been described clinically, or at least nothing that we're aware of. The collecting duct absorbs so little bicarbonate that we don't have a reclamation problem of bicarbonate absorption due to the collecting duct. Clinically, most of the diseases affect the proximal tubule, and that's why we use the term proximal RTA. But theoretically, we could have a bicarbonate reclamation problem in the thick ascending limb and the collecting duct. We just don't see that clinically. Now, there's something else that has to happen to keep the bicarbonate constant, and that is the problem that we have protons secreted by the hepatic vein into venous blood every day because of the amino acids we eat. Cysteine and methionine are in the meat and the protein. The different sources of protein that we eat create sulfuric acid, and arginine and lysine hydrochloride that are also in the meat and the fish we eat create hydrochloric acid. And the total amount of protons created every day is around 50 milliequivalents per day. Now, that is going to consume bicarbonate, no different than if you started a hydrochloric acid IV or a sulfuric acid IV. I guess you could do if you wanted to. We don't do that clinically. But those protons are going to bind to bicarbonate. They'll make carbon dioxide that our lungs will get rid of, but now we'll have a metabolic acidosis. It's no different than having a proton coming with lactate or a proton coming with beta hydroxybutyrate. Doesn't matter. Protons are going to bind to the bicarbonate and lower it. And so it's very important that that doesn't occur, or if you do the math, in about 2 weeks, you'll have a bicarbonate of 0 also. So you could have a bicarbonate of 0 either because you didn't absorb the bicarbonate, that's the slide before this, or you could absorb it, but you couldn't compensate for the protons that are being secreted every day into our hepatic vein because of amino acid metabolism. And so something else has to occur to prevent that from occurring. Now, it isn't always in all humans that we're making 50 milliequivalents of protons a day. It depends on the type of amino acids in our diet. So people have come up with this kind of dietary chart, and they're so-called acid-producing foods such as cheese and egg yolk, which is the worst, versus amino acids that tend to make bicarbonate, such as raisins and spinach. These are base producing. So it depends really what the complement of all the food you eat in a 24-hour period is. And in a typical North American diet, most people aren't vegetarians eating spinach and raisins all day or fruit. If you were, you would never make protons in a net sense. You'd be making bicarbonate, and all the kidney has to do is dump the bicarbonate. But in an average North American diet, you tend to be on the acid producing side, around 50 milliequivalents a day. And it's the liver pumping it into the body. So how do we prevent ourselves from having a metabolic acidosis? It turns out it's the kidney. The kidney generates about 50 milliequivalents of bicarbonate a day. This is new bicarbonate above what it reclaimed from the glomerular filtrate to match the daily hepatic proton load, such that you don't end up with a metabolic acidosis. You generate carbon dioxide from this reaction, but the lungs just get rid of it, assuming you don't have a pulmonary ventilatory problem. And now you've prevented your blood from having a drop in the bicarbonate concentration. It turns out in CKD and ESRD, it's the inability of the kidney to generate new bicarbonate that leads to the metabolic acidosis. So if someone says to you, why does my patient with CKD have a drop in bicarbonate that we focus on so much when we're trying to keep the bicarbonate close to the normal range, or in ESRD, where we're giving lactate to stop and prevent the metabolic acidosis, where the carboxyl groups on lactate are generating bicarbonate, whatever the cause. In CKD and ESRD, the reason for the fall of bicarbonate in the first place is because the kidney can't keep up with the daily hepatic proton load. So if in your patients, CKD patients or patients with ESRD, you put them on raisins and spinach all day, or made them vegetarian, they wouldn't have this proton load, and you wouldn't have the same drop in the bicarbonate concentration that you would see otherwise. So one way to get around it, in lieu of giving them citrate or bicarbonate, or even needing as much lactate in PD, or correcting the bicarbonate on hemodialysis, is just to change their diet. It's just the problem is humans don't change their food intake for more than maybe a week after an MD asks them to. Not just patients, MDs don't change their diet either. So changing the diet is one of the hardest things that you can do, no matter how much you try. But if you did, you could focus on the input side in your patients too, and raise their bicarbonate. So getting back to blood gases, what's measured, as I said before, the pH and the PCO2 are measured with electrodes, and the bicarbonate is calculated from either this equation or the full Henderson-Hasselbalch equation. So then what should be measured then? What are assessed? I mean, what should be assessed when you're confronted with a whole slew of complicated numbers? If you think about it, we get the total CO2 from the chem panel, and we have all these numbers that we get when we're asked to make an acid-base diagnosis. So you need to have an approach, and the approach should be the same in every single patient. And again, it's called the bicarbonate-centric approach, which means one thing and one thing only. When you're asking yourself, or another human being asks you, what is the acid-base diagnosis? You do not look at anything other than the bicarbonate or the total CO2. The total CO2, it can be used because in most clinical situations, the PCO2 doesn't contribute to this enough such that it's basically the same number. It should be like one higher than the bicarbonate in the ideal world. Now, it can be a little bit higher because on this side, it tends to be venous, and this side is arterial. And remember that the total CO2 in the venous side is not the same as the total CO2 on the arterial side, for the same reason that the PCO2 is not the same and the bicarbonate's not the same. And remember, this is the sum of the PCO2 and bicarbonate. So ideally, you would be comparing a venous total CO2 to a venous gas, or arterial metabolic panel to arterial blood gases. In the real world, we don't. So don't expect that they're going to be as close if you're mixing mixing types of blood. But the take-home message is we have four numbers typically that we're confronted with when we're asked or we're thinking of making an acid-base diagnosis. And the thing you have to stress over and over again and make yourself do is ignore the pH and ignore the PCO2 initially and just cross them out. Don't look at them, or you're going to never be able to make accurate diagnoses of especially mixed acid-base disorders. You'll never remember the acid-base rules that you have to remember to pass your exams and to make clinical diagnoses accurately. So again, the bicarbonate-centric approach means what it says. It means only look at the bicarbonate or the total CO2 if you don't have a gas initially. And then you ask yourself the following question: is the bicarbonate or total CO2 normal, increased, or decreased? Now, if it's decreased, either the total CO2 or the bicarbonate, it can only be one of three acid-base disorders. It's either metabolic acidosis, acute respiratory alkalosis, or chronic respiratory alkalosis. So as a renal fellow, you should be thinking always of metabolic acidosis and respiratory alkalosis, but don't just say respiratory alkalosis because there's always two types. But if you just remember that there's always three choices, it'll force your mind to think of the three. Divide up the respiratory acid-base disorder, and you've only got one metabolic that'll do this. But the problem we're confronted clinically and chemically is not only is the total CO2 and bicarbonate down, but the PCO2 is always down in all these three. So it doesn't help us. We have a drop in our total CO2 bicarbonate, and we have a drop in the PCO2. So the way we make the diagnosis is the concept is that the change from normality of both the bicarbonate and PCO2 differs for each of these. And that's why you have to memorize what those changes from normality are. And that will allow you to distinguish which of the three it is. So in all three acid-base disorders, the total CO2 or bicarbonate and the PCO2 are decreased. But what allows us to make a diagnosis, both for your boards and clinically for the rest of your life, is that the change in bicarbonate from normal compared to the change in the PCO2 from normal is what distinguishes these three. And that is just something that needs to be memorized. So let's look at metabolic acidosis. Again, we have a drop in bicarbonate and we have a drop in the PCO2. Now we have a name for that. Again, the initial thing that happened is a drop in bicarbonate, either from a proton load, from lactic acidosis, or the kidney can't absorb bicarbonate, proximal RTA, whatever it is. That's the initiating event. But the PCO2 also drops. And that's because we get this change in our ventilation that occurs in these situations. And we call that respiratory compensation or the compensatory response. If it's what we predicted will occur, and I'll show what that is in a minute, you do not call that respiratory alkalosis. You do not call that secondary respiratory alkalosis. In fact, you never use the word primary or secondary when you're making an acid-base diagnosis, because when you say someone has a respiratory acid-base disorder, it implies that it's primary. You don't have to use the word primary. And you don't call the ventilatory responses in metabolic acid-base disorders secondary respiratory alkalosis. So you never have to use the word secondary. So that's another teaching point from this lecture and for the rest of your life. Never use the word primary or secondary anymore when you're using words that are associated with acid-base diagnoses. Just rid that from your vocabulary, because number one, it's going to confuse you both as far as chicken and egg, and secondly, it's erroneous as far as physiologic responses and medically. So we're talking about the same thing over and over. What are the expected then changes in bicarbonate and the PCO2 in metabolic acidosis? And it's known just empirically. There's no rhyme or reason for this. This is just phenomenology that was based on making measurements in the real world. And what was found was that for every 10 change in the bicarbonate, the PCO2 changes by about 12. Or if you like to use another rule, 5 to 6, or you can use 1 to 1.2. It doesn't matter. The relationship is the same, that for every, or 20 to 24, whatever your brain wants to memorize. So for example, if the bicarbonate is 14, that's a decrement of 10, you'd expect the PCO2 to fall 12 from its original value as the ventilatory or compensatory response. So if it started at 40, it would be 28. And if you see a PCO2 of 28, you do not call that a respiratory alkalosis or a secondary respiratory alkalosis. You call that appropriate compensation. It's not a respiratory acid-base disorder, because when you say secondary respiratory alkalosis, or even erroneously call this a respiratory alkalosis, you're telling another human brain that that patient has a problem with their ventilation. That's the only time you should use the word respiratory acidosis or alkalosis, when you want to convey there's a problem with the lungs or the medulla. If it's just what you expected, that's perfectly normal, and you don't call that an acid-base disorder at all. It's just appropriate compensation. It's a simple metabolic acidosis with appropriate ventilatory compensation. That has nothing to do with respiratory acid-base disorders. Now, what about anion gap? Anion gap, again, confuses people. Basically, it's just the concept of electroneutrality. The positive charges in a solution always equal all the negative charges when you add them up. It's just that we don't measure all these charges clinically. If we did, we'd have no reason to have a concept of anion gap. It's just that we only measure the sodium and chloride and bicarbonate typically. Now, some people here throw in the total CO2. That's fine, assuming that you don't have a severe respiratory acid-base disorder, because then this won't equal the bicarbonate. You really want to plug in the bicarbonate. But at any rate, this doesn't just equal unmeasured anions, as people think. You have to take it's algebra. You have to take all the negative charges and all the positive charges that we don't know. That's what these represent. I mean, if you wanted to measure them, you would know them. But since we are calling these, and it's a human definition, unknown, doesn't mean they're not unknowable. They're just unknown to you because you're not measuring them. What it equals is the unmeasured anions minus the unmeasured cations. Now, don't forget that there's unmeasured cations. What are they here? There's calcium, magnesium. There's something called IgG, and people don't realize that IgG is positively charged. And so it really needs to be included in this definition of unmeasured cations, because if your IgG level goes up, your anion gap's going to go down, right? This difference will get less. And in multiple myeloma patients, due to IgG, they can have a low anion gap because this charge went up. And usually what happens is, which of these changes? It's usually the chloride, because when you have IgG coming into the body with myeloma, you don't just have IgG coming in, or you'd have your blood would spark. You'd have a difference in charge. It's IgG chloride that comes into the body. So the chloride goes up, and that's why the anion gap falls when you do your calculation. Bicarbonate is 24, and the sodium is 140. Okay, so when you have an anion gap metabolic acidosis, you have to think of chicken and egg too. People often erroneously implicate the anion as a cause of the metabolic acidosis. The lactate is an innocent bystander as far as the metabolic acidosis. It doesn't change the acid-base status at all. The lactate that comes in, or the beta-hydroxybutyrate, it raises the anion gap, but it doesn't cause a change in your bicarbonate. The reason we typically associate lactate coming into the body with a metabolic acidosis, or a drop in the bicarbonate, is because the lactate doesn't come in with sodium or potassium. If every time you had myocardial infarction and you had lactate building up in the blood, and the lactate came in with calcium, you would get hypercalcemia with the lactate. Or if it came in with potassium, we would get hyperkalemic. It doesn't. It comes in with a proton. And that's why we call it a lactic acidosis. But it's not the lactate that's causing the change in bicarbonate. In fact, we use lactate in our TPN solutions to raise the bicarbonate, and that's because the carboxyl group on lactate, when it's metabolized, generates bicarbonate. In the lactic acidosis, if the metabolism of the carboxyl groups on lactate temporally exactly matched the rate at which the bicarbonate fell from the proton coming in, you'd never see a change in your bicarbonate, because the bicarbonate generation from the lactate would exactly equal the rate of proton causing a decrement in the bicarbonate. It's just that the metabolism of the carboxyl groups is much slower. So when the proton comes in, it immediately lowers the bicarbonate, and then the lactate, as it's slowly converted into bicarbonate, ameliorates the metabolic acidosis. In fact, the lactate is a good thing because it's actually correcting your metabolic acidosis when it's converted to bicarbonate, as same sort of thing with ketoacidosis. The ketone bodies are converted into bicarbonate over time. So again, we have two substances coming in that happen to be coming in at the same rate. And so we get these things changing in opposite directions. Now, to the extent that the lactate or beta hydroxybutyrate is converted into bicarbonate, the anion gap won't go up as much. So the anion actually can affect the anion gap, or it can be metabolized into bicarbonate. Never forget that. So in metabolic acidosis, you have to ask, is it compensated or not? In other words, is the ventilatory response and the surrogate for that is the PCO2, what you expect it to be, the 10 to 12 rule or 5 to 6, whatever you want to memorize? Or is the anion gap changing or not? Now, the other two possibilities, remember there's always three in the up or down direction, is acute and chronic respiratory alkalosis. Now there, the chicken and egg is different. Here we're talking about a problem with the PCO2 side. And the reason we divide it up into acute or chronic respiratory alkalosis is you get a different bicarbonate depending on when it's occurring in the patient temporally. And I'll show why that is now. So it brings up the very simple question, why does the bicarbonate decrease in acute respiratory alkalosis? And it's no different than opening up a bottle of Coca-Cola. Why does the bicarbonate decrease? Well, the first thing to know is it's very fast. It only takes 5 or 10 minutes after you achieve a certain PCO2, and it has nothing to do with organs. That's the key concept. In acute respiratory alkalosis, the change in bicarbonate is solely due to the fact that you're out of equilibrium now. You're shifting the bicarbonate buffer reaction because you're lowering the carbon dioxide concentration in the solution, and that drives all these things to the left, and bicarbonate gets consumed. Now, if you had no other buffers, your proton concentration would drop by whatever your bicarbonate concentration dropped. It's just that other buffers, which I'm not showing here, like albumin, phosphate, amino acids, deprotonate and release their protons, keeping this roughly the same. But the bicarbonate drops, and it drops a predictable amount. So we'll show that in a second. Now, then why do we have this distinction? Why don't we just say acute respiratory alkalosis? The bicarbonate buffer reaction was shifted, the bicarbonate falls, and that's because if you keep, let's say, have a patient with a PCO2 of 40 and drop it and then keep the PCO2 down over days, yes, initially the initial fall shown in red here was due to the bicarbonate buffer reaction, but that's over in 5-10 minutes. But if you follow the patient and keep measuring bicarbonates or total CO2s every day, you're going to find that even though the PCO2 is not changing, the bicarbonate continues to fall until a new steady state is reached, at which point we call that chronic respiratory alkalosis, and that's due to the kidney. We won't get into today how that occurs, but I do want to say that if you don't have a kidney, if you have ESRD, it's never going to fall like this. It's always going to look acute. So you can be fooled. And a patient with ESRD, they don't have such a thing called chronic respiratory alkalosis. Okay, their bicarbonate always falls what it would fall if in the first 5-10 minutes and just stay there. I don't have a dotted line here, but the fall would be just always looking acute. So you lose the ability to distinguish acute from chronic respiratory alkalosis if you have someone with ESRD. So remember that someone with ESRD, by definition, can never have chronic respiratory alkalosis. So what are the expected changes again? So first, in acute respiratory alkalosis, for every 10 fall on the PCO2, the bicarbonate falls by 2, solely due to the bicarbonate buffer reaction. If I drop the PCO2 to 30, the bicarbonate will fall. If it started at 24, it'll be 22. And you can remember 5 to 1 if you want, or 20 to 4. It doesn't matter. The relationship is there's 5 times as much change in the PCO2 as there is in the bicarbonate in the down direction. In chronic respiratory alkalosis, because of the kidney, which doesn't occur in ESRD patients, the bicarbonate falls an additional 3, so that the total fall is 5. Two out of the five fall was from the bicarbonate buffer reaction, opening the bottle of Coke. The bicarbonate falls because you're driving the reaction to the left, and a further fall of 3 was due to the kidney. So again, with time, it falls further, and it takes a number of days to reach a new steady state. Now, what about the up direction? Let's say, again, we look at these numbers and we find that the total CO2 of the bicarbonate is increased. Again, we have 1 of 3. It's always 1 of 3. So memorize that. There's only 3 choices all the time. It's either metabolic alkalosis or acute respiratory acidosis or chronic respiratory acidosis, but we're faced with the same complexity, and that is that the PCO2 is increased in all 3 disorders. So metabolic alkalosis, we have an increase in bicarbonate. We also have an increase in the PCO2. We do not call that secondary respiratory acidosis. We do not call it respiratory acidosis if the change in the PCO2 is what we expected it to be. We call it like in metabolic acidosis. Concept is exactly the same, although people don't realize there's a compensation in metabolic alkalosis too. And as a renal fellow and a nephrologist, you have to start remembering that. You don't just have a compensation in metabolic acidosis. You have the same thing occurring in the up direction. And there's no reason a priori to think it would be any different. It shouldn't suddenly just be occurring below 24. It occurs over a whole continuum, except in the up direction, we decrease our ventilation. But we still call that the compensatory response. And it's known what that should be. For every 10 increase in the bicarbonate, the PCO2 goes up by 7. So if the bicarb goes up by 20 from vomiting, the PCO2 will go up by 14. So you can remember whatever relationships you want. But for example, if the bicarbonate went to 34, which is an increase in 10 from normality, the PCO2 would go up by 7. So if it started at 40, it would be 47. And again, we call that the expected compensatory response. We don't call the 47 respiratory acidosis. We don't call that secondary respiratory acidosis. We just say that the patient had the appropriate compensation, and it's a simple compensated metabolic alkalosis. Remember, for metabolic alkalosis, we don't divide it up by anion gap. We divide it up by whether it'll be corrected by chloride or not. We use the urine chloride as a surrogate to assess whether it'll be corrected or not. We don't have low chloride patients and high chloride patients. We have low chloride patients and normal chloride patients. The chloride is not high in the group that doesn't respond to chloride. The point is, it's just no different than yours or I would be on the same water intake and dietary chloride intake. It's normal. But these patients have a chloride concentration in their urine that's below what you would expect for their chloride intake, and they will respond to chloride-containing salts. And we went over the last number of weeks in the metabolic alkalosis talks how chloride does that. So we decide, is it compensated or not, based on the PCO2 and whether the patient's metabolic alkalosis will be ameliorated by giving chloride. As far as respiratory acid-based disorders, we divide it up by time. Again, it's the PCO2 going up, and we find we have to divide it up by time because for a given PCO2 change, the bicarbonate will not be the same if we wait long enough. And we find the same phenomenology in that here we're bubbling the solution with carbon dioxide and we're driving the reaction to the right. So acutely, again, 5 to 10 minutes. If we do this, we're generating bicarbonate. Yes, we are generating equal amounts of protons, but these protons will bind to other buffers. So this proton concentration or the pH hardly changes. And we end up generating bicarbonate. And it's known how much bicarbonate will be generated in the up direction. Here we have the PCO2 going up and we keep it there. We're going to get this acute increase in bicarbonate. But if we keep the PCO2 elevated, we find every day the bicarbonate keeps going up and up and up and up and up, even though the PCO2 is not changing. And that, again, requires a kidney, and again, will not occur in ESRD. It'll always look acute. So you can't have a chronic respiratory acidosis either if you have ESRD. You cannot increase your bicarbonate like this. It always looks acute. And the rule is, if it's acute, for every 10 increase in the PCO2, the bicarb goes up 1. Remember, for the down direction, the bicarb falls by 2 acutely, but in the up direction, it goes up by 1/10 of what the PCO2 went up. So you can remember again, 20 to 2, 10 to 1, 5 to 0.5, whatever you like to remember. Chronically, the bicarbonate goes up another 2.5 above what it was initially for every 10 increase. So the total is 3.5. And again, that's due to the kidney. If you don't have a kidney, it'll always be up by 1, no matter how long you wait. So again, patients with ESRD cannot have, by definition, a chronic respiratory acidosis picture. Now, there's additional clues that a respiratory acid-base disorder is present, and that's this following subtlety, but it's very important for your practice and for your exams. Metabolic acidosis or alkalosis is present, but the respiratory compensation is not what you predict it to be. By definition, that means that you have more than one acid-base disorder, and it means you have a respiratory acid-base disorder. So the lack of the appropriate compensation, remember, the compensation is not called a respiratory acidosis or alkalosis, but the lack of the appropriate compensation means, by definition, in addition to the metabolic disorder, you also have a respiratory acid-base disorder. So let's take, for example, a patient with a bicarbonate of 14 due to a metabolic acidosis. You would expect the PCO2 to be 28. Right? This changes by 12 for every 10 change in the bicarbonate. But the key point is this: if the PCO2 is above 28, let's say it was 32 or 33, that is called a respiratory acidosis because it's above what is expected. And that confuses people. They go, oh, I thought, Dr. Kurtz, above 40 is a respiratory acidosis. That's true if your bicarbonate's 24. But if you have a metabolic acidosis, and the bicarb fell from 24 to 14, a drop of 10, the PCO2, if you have a normal medulla and lungs, will be 28. So that is your new norm, not 40. And everything above 28 then becomes respiratory acidosis. And the converse is that everything below 28 is called a respiratory alkalosis. You don't call that primary or secondary. It's just if it was 26 or 25, the patient has a metabolic acidosis and a respiratory alkalosis. You don't use the word superimposed either. You're not saying anything when you say superimposed. When you say they have both, you're saying they both occur at the same time. You're taking a snapshot at that point in history. So if they have a bicarb of 14 and a PCO2 of 26 or 25, they have a metabolic acidosis and a respiratory alkalosis. If their PCO2 is 32, 33, 34, 35, anything above 28, they have a respiratory acidosis in addition. So this is a really important slide because people fail to, first of all, know what the expected PCO2 is, both in metabolic acidosis and metabolic alkalosis. And then once having predicted what it should be, fail to diagnose an additional respiratory acid-base disorder when it's not what you predict it should be. So this is a really important slide. So again, we divide up metabolic acidosis by anion gap, alkalosis by chloride, respiratory acidosis temporally. We do not use the word compensation in the respiratory acid-base disorders. We just use the word acute or chronic. That's it. No other subdivisions, no other terminology. And because of the time, I'll end here, but I just wanted to say that you have to be aware of the time it takes to reach these changes, because in between, it looks like you have a complex acid-base situation. You have more than one acid-base disorder, and it's not that. You just haven't waited long enough. So in metabolic acidosis, it takes half a day to a day for the compensation to become complete. If you come in between the creation and this time, you're going to think there's a respiratory acid-base disorder in addition because the compensation isn't what you predicted it would be. It's not that. You just haven't waited long enough. And the same with metabolic alkalosis, that actually takes a bit longer. With acute respiratory alkalosis and acidosis, sorry, this should be acidosis here. It's 5 to 10 minutes, so it occurs quickly. And the respiratory, chronic respiratory acid-base disorder, it takes days, and you can be fooled also into thinking you have a mixed disorder or there's something going on with the ventilation, even though there is, or excuse me, with the bicarbonate number, even though it isn't. So I think I'll stop there. Try to remember these time points too. It's a mistake many people make on the wards, and it's going to prevent you from making an accurate acid-base disorder. So I think because of the time, I'll stop today and take any questions if anybody has. Okay, everyone, have a great day.